Hello and welcome back to Two Guys in Scrubs. We are Two Guys in Scrubs. I'm Silas Rades.
And I'm Delbert Yip. We're second-year medical students at the University of British Columbia, and we started this podcast to share what it's like going through medical school, discuss medicine, and pretty much anything else.
Please be advised that Two Guys in Scrubs is for educational and entertainment purposes only, and the views expressed do not reflect the views of our program or supervisors. Hello, Mr. Delbert, my good friend. How are you?
I'm doing well. How are you?
I'm doing really well. I'm actually lucky. I'm sitting on Bowen Island right now, which is a small Gulf island near Vancouver, and I'm sitting outside. It's a beautiful day. I'm overlooking the ocean. I am totally spoiled right now, so I am fantastic.
Great. I think this is our second episode of the year. I was going to say it was our first, but the shock and trauma of our midterm last week might have just wiped those memories from my brain.
Well, you wouldn't be wrong. It is our first episode of the Chinese New Year, at least, so you got one calendar correct.
And that's passing.
You are. It is passing. And for all our listeners, you are of Chinese descent, are you not?
I am.
There's a little fact about Delbert. So here's a quiz question for you. What year on the Chinese calendar is it this year?
It is the horse, and if you add the astrology to it, it's the fire horse.
Wow.
Yeah.
Well, that's very interesting. And
I don't know what it means, to be honest. You can go pretty deep into this stuff, but that's all.
Well, it sounds so dramatic. I almost didn't have anything to say. I was kind of floored. It brings up very tantalizing imagery. But moving on, everyone will be very excited. We are back with another special guest episode, and we are I'm personally really excited for this episode because we're able to get a fantastic guest who's very involved in the UBC Medical School curriculum. As our listeners know, we like to talk a lot about what it's like going through medical school. So it's so cool to have someone here who's involved in our training. So our guest today, our very special guest, is Dr. Julia Wimmers-Klick, who is a medical doctor trained in Austria and Germany, who somehow managed to combine head and neck surgery, anatomy labs, interprofessional education, AI, and faculty development into one coherent career. She began as an ENT surgeon, performing over 1,000 surgeries independently, then pivoted into medical education in Canada, where she now serves as tenured Senior Lab Instructor at UNBC and Assistant Professor of Teaching with UBC's Faculty of Medicine. She's the Regional Co-Director of Faculty Development, Portfolio Site Lead, and Anatomy Lead. Her research ranges from cochlear implants to rethinking assessment in the age of generative AI, from interprofessional education in rural settings to the history of Canada's pioneering women in vascular surgery. She teaches across the curriculum with a focus in year 1 and 2, and she enjoys teaching and having a positive, at least she hopes, impact. In short, she builds learning environments the way some people build cathedrals, with precision, humanity, and a little spark of joy. And without any further ado, we are pleased to welcome Dr. Julia Wimmers-Klick. So hi, Dr. Wimmers. It's a pleasure to welcome you to Two Guys in Scrubs, and it's an absolute honor and a pleasure to have you with us today. Do you prefer Dr. Wimmers or should we call you Julia?
Julia is totally fine. And the pleasure is all on my side, actually. It's exciting to be here. Thank you.
So we are Two Guys in Scrubs, of course. It's my understanding you don't necessarily identify with Guy, but do you identify with Scrubs?
I take the Guy as well.
Okay.
No, absolutely. Yeah, I identify also as the Scrubs part.
Great.
Of course, everybody's already heard your bio, but it's just it's fascinating to think about how long of a career and how diverse of a career you've had, from ENT to now medical education and so on. So we're really excited to talk to you, especially because, here on Two Guys in Scrubs, we like to talk a lot about our experience as medical students going through school. And we often reflect on what it's like going through the program, and everything that comes with that. So to have someone who's actually involved in our curriculum and involved in our program, it's really exciting, and we'd love to kind of explore that with you today. Delbert, why don't you kick us off? Let's get into it.
Okay. So Silas just talked about our interest in the curriculum, and so Dr. Wimmers or Julia, a lot of our curriculum is based around these competencies. And I wanted you to
Mhm.
tell us a little bit about these competencies, why they were chosen, and why do you think they are so important?
Oh, that's a good question. So maybe we have to go back in history a little bit. When I went to medical school, and this is already over 30 years ago, um, we only focused on knowledge and skills. We didn't have any classes or courses or where communication skills or collaboration or this kind was handled or taught or practiced.
Hmm.
There was also not a place for reflection. It was really purely science, evidence-based knowledge, and skills. This was the only competencies which the medical schools, and I'm a little bit reluctant to say medical school because I went to a University of Medicine, which I think it's a different, but this was their only focus. And then they realized, hey, actually, we like to have like good physicians. It's not only defined by their degree of knowledge. So to be a good
Hmm.
physician needs more, right? You um, need to be able to connect with a patient. You need to work in a team, to know how to advocate for your patient, and so on. And so they realized this is missing in the curriculum. And then they sit down and said, okay, what are our competencies which are important for being a good physician, and how do we incorporate it in our curriculum? And then the CAN-MEDs, I
Hmm.
think you know these flowers with
Yep.
all these competencies, were established and implemented in the curriculum. So and here is, and this is my little critical thinking, here is where I think we have to be careful, because I do understand that the pendulum from one extreme, only knowledge, now goes a little bit too much in the other direction, where
Mm.
but it is good that we focus on these competencies. That's not what I'm saying. I'm just sometimes I worry that we have not enough time for the knowledge part in our curriculum. That's like where I see a little danger.
Right.
So, and also the feedback sometimes which I get from students when they say, oh, so many hours we spent with history taking and observing the other and history taking and so on. Is this really what we want to reach? Is this really the like when we spend so much time, for example, history taking in the first 2 years in clinical skills, is the outcome equivalent to that what we put in time-wise?
Hmm.
Or, and this is also a little bit provocative question, or later on in the clinic, the hidden curriculum takes over anyway. They find their role models and they copy how their role
Right.
models do the history taking. So that's
Yeah.
like something which we could reassess when we reassess the curriculum at one point. But the important part is that to be a good physician, knowledge alone is not enough. But it is
Hmm.
also very, very important to have good knowledge. and we are also shouldn't forget this part. Um, but to understand the competencies we created for the medical school or for this medical school is very heavily focused on, let's say, soft skills.
Mm. That's so interesting, and I think, yeah, I have so many questions right off the bat, but I think I'll start here. Yeah, hearing you speak about those ideas, the first thing that I think about is just a general approach to teaching anything. and how there's kind of a more classical system and maybe a more modern system, to put it in a very simple way. For example, like if I think about learning even something like playing piano, or maybe even a martial art, for example, or an artistic sport like gymnastics, a classical approach would say that we need to do years and years and years of the dry fundamentals until they are mastered. You don't get a chance to. I mean, even there's for example, if you think about Indian classical music, the students, like, they're learning how to play the percussion instruments. They don't even get to touch the actual drum until they've mastered the theory and being able to even make the sounds with their mouth. And I think there's a classical system would say that if you become an expert at the fundamentals that are not very exciting, that they kind of the more the soft skills will almost emerge on their own, out of this really strong foundation. I think in a classical approach to medicine, we might say that becoming an absolute expert at anatomy and physiology and pathophysiology, that I think the idea is that if you're a master, then everything else will be allowed to emerge. But I think I'm not saying that that is true. I don't think it's objectively true, but I think we're exploring other avenues. But I think that would maybe be at least my view of the more classical approach. And two would be, I would have a question with when you try to teach soft skills, and I'll take it to the extreme. I remember early on in medical school in first year when I was in a communications session where we're getting specific instruction on how to have good and effective communication skills. It would even get to be so like teaching implicit skills so explicitly that teaching you how to sit, or if the patient leans right, then you lean left, things like this. So and I think maybe when it gets taken that far, that it doesn't really allow implicit things to come out on their own. And like you said, people are going to default maybe to their own personalities or the hidden curriculum anyways. And as I'm speaking, I just realized that I didn't ask a question like whatsoever. I just those are my. I just wanted to share those reflections, and maybe even Delbert, if you have a follow up, or Julia, anything that you make, anything that you want to respond with to that would be great.
No, that's very interesting that you kind of put it in the classical approach and the modern approach, and I guess there is not really a right and wrong. So the medical curriculum right now, as you're well aware, is in a spiral approach, right?
Yep.
And you are kind of thrown into it, and you try to swim and learn everything a little bit, and then you try to stay on top, but doesn't really understand deeper connections because you don't have the time for deeper learning. And I think I compare it to when you are going to a different country with a different language, and you try to learn the language by living there. You have roommates who speak this language, and you try to understand and try to learn the language. Or do you sit, or how we learned the language in school, we had to learn the grammar and vocabulary forever till we were able start to speak. And this is a little bit comparable to the curriculum structure we have. So this spiral kind of is you should learn the art of medicine being thrown into the cases from day one on, and not like compartmentalizing. Now I only learn about the heart or only learn about this and that. I think it kind of depends how your brain is wired. I would find it very difficult. I'm more the vocabulary and grammar studying type and then try to speak. But it kind of works for the students, and I admire them that they start swimming and don't drown.
Well, if I had one,
Yeah, go ahead.
If I had one thing to say, we don't really have a choice, right? We
No,
start with a spiral and we can't really, stop the spiral, so to speak.
yeah.
Silas and I have both tried. I'm sure Silas can talk about his approach maybe, but personally, I haven't really followed the lectures since maybe year one. And I found that that's helped me a lot because it's allowed me to consolidate a little bit more.
Mm,
As you mentioned, the more finer details and the pathophysiology. However, I wanted to get back to something that Silas was talking about, the communication skills sessions that we often have up until year two, actually. And one of my tutors in those sessions told me that at first, when she began teaching these sessions, she felt kind of skeptical that you could even teach good communication or empathy. But over
mm,
the years, she told us that she became convinced that this was effective. Maybe it's not the most efficient way of doing it for everybody, but for certain people, it may actually be helpful. So maybe, there are some people who benefit from this and then some people
oh, yeah,
who
no,
probably don't.
absolutely. Like, practice is always good, and you learn in small groups, so you do see how your peers are struggling or how your peers are developing, or you have one who's very good in asking empathetic
Mhm,
questioning, and you think like, wow, I learn from this person. Um, I I'm also the portfolio site lead, and as you know, portfolio is quite a bit about reflection. And
mhm,
then sometimes we receive submissions from students where there is no whatsoever reflectional thought in there. It's just a description of the situation. And so I went a little bit into research and were specifically looking, is everyone able to learn how to reflect?
mhm,
And there is research out there that says, well, there are individuals who are not able to learn this.
mhm.
Um, Most of them are, and we should help. But it is not that everyone is able. And I think this also is probably true for being a good communicator. You, most of us can learn it and can improve. But there are a few individuals who will never really be really successful in this area, if you can say successful in communication. But the nice thing I always say is medicine has such a wide range of specialties which are so different. Like if you are not a good communicator whatsoever, then you can go into some areas where you don't need it. And you can even go now you can argue, well, still have to communicate with your team, for example, radiologist or so. But there are other areas where it's very, very important to have good communication skills, like for a family doc, for example. Um,
Mhm.
but in medicine, depending on your strength, there are definitely niches where you can fit in. Um, and not everyone has to be good in everything and cannot be
Yeah,
good in everything, right? Like even if you try hard.
I agree, and that's like you said, it's a part of the beauty of it. And I want to move on to another topic, but before we close the loop on this question of competencies and training, I do just want to make a point because I think one of the benefits of the modern approach, just to circle back to that theme, is that we can, there are criticisms that can be offered about it, but something that is unambiguous is, if I think about this a couple of weeks ago when I was doing a family medicine placement and just working with a family doctor in the clinic for a day, I know that my ability to do that as a second year is so far beyond what it would be if I had only done a year and a half of anatomy and physiology so far. So unambiguously, I'm prepared for the actual role of being a doctor earlier on in my career. That is unambiguous. So what are the 10, 20, 30-year outcomes of this training? I couldn't tell you, but I can at least say in the near term that I feel more prepared for the job sooner than if I was just doing theory. So
that's a really good point. Because you have only 4 years to become a physician here, right? It's only 4 years long. That's not long. And we don't have the time, because you're not starting after high school, you don't have the time to go 7 years or so to medical school. And so actually it is a very high intensive, very fast pacing program, which is good because you all have already a bachelor or a career or whatever path before, and cannot take forever. And so starting on day one has a lot of positive aspects as well. I
absolutely.
just wanted to point out that knowledge and skills is like, yes, I'm kind of an advocate not to further decrease the time in your curriculum for knowledge and skills, because it is a foundation, right? And when you don't have a foundation, then you're wobbling around.
Yeah, absolutely. And but okay, maybe we can take it in this direction after you said that. So here's maybe a provocative question to start, which was, if we think about knowledge and skills, and in particular, I'm going to say if we think about rote knowledge, the classical physician's ability to access a seemingly endless encyclopedia of facts and information in their brain, which is without a doubt, extremely important to the job. But in the age of AI and technology, where of course, where the role of rote memory and the value of rote memorization seems to be decreasing year by year, and increasingly so, at least in my opinion, what is needed more than ever with when we have access to this type of technology is the ability to ask the right questions and not necessarily be able to access a fact in the back of our brain because we can access the fact with technology so quickly. So any reflections you have about how AI and technology might be changing the value and the need for certain classical competencies like we were discussing, and even you could take it in a direction might be interesting when the curriculum and people who design the curriculum and participate in that process, like yourself, when you know that these technologies are available and when you know students are going to be using them for sure, are there certain aspects of our training that you think are beginning to be removed because AI is kind of threatening the utility of doing that? And are there aspects of the curriculum that you're trying to add in the light of these technologies and knowing that the students will be using them?
Okay, complex question.
Sorry, that was too much. I mean, I guess that was 2 parts.
No, it's a good one. Thank you. So, using AI, like AI is here to stay, right? It is, we cannot forbid it or we decline it. And everyone uses it, and I use it as well. But my generation grew up without AI. So when we use it, we go through whatever AI gives us and edit it. When you don't learn how to edit, then it becomes problematic. So the question is, how can we teach students or children or whoever how to edit? And this is like a philosophical question, like, can you edit without being a master in it or without having learned the skill? The problematic part is when we are not able to critical question it what AI gives us, when we are not having the ability to differentiate what is correct or what is necessary or what is important for whatever we asked AI to do. And this, how to teach that people are able to edit. That, I think, is the biggest question which I cannot answer. But I think not only we in medical school, but in every school, in every family, this is an important question, like, which brings it to critical thinking, right? And so I think we should more focus on how to train our students for critical thinking. I'll add it as one part, but then also critical thinking. And then the next question would be, how do we implement this in the curriculum? We are trying to portfolio or to or special CBL cases with ethical question, but like critical thinking will be more and more important in our society, I believe. And then to the second part of your question, do we change the curriculum or the assessment tools we have because of the AI, the potential AI use? And for example, in portfolio, you can write beautiful reflective pieces within 10 seconds. Or AI can write this. And this is not what we want, right? And the coaches can put this into ChatGPT and say, give me a feedback. And so ChatGPT talks to each other. And this is then absolutely ridiculous, right? I think what we as teachers, instructors, preceptors need to focus on more, and we haven't really learned this, to activate the intrinsic motivation in the students to learn, so that they want to learn it themselves, that they want to learn, that they're interested in it, not to outsource this into AI. So more focus on how to increase the intrinsic motivation to learn something or to write in a reflective piece in the case of portfolio. Does it make sense?
Yeah, I think that was really helpful. Salas, if you have anything to add to that?
No, I think I'd be interested to maybe I'm just noticing our time here. I'd love to talk to Julie a little bit about her experience working primarily in Prince George. If you want to take it there, that'd be great.
Oh, yeah.
But working in Prince George?
Oh, sorry. No,
Yeah.
I was handing it off to Delbert. I think.
Okay.
Oh, okay.
Delbert could take the lead in prompting you in that direction. That'd be great.
Yeah. Yeah. So both Salas and I are based in Vancouver, and we haven't really explored the other campuses, but we understand, obviously, that BC is enormous and wildly diverse, and there is a lot of focus in our CBL cases and throughout our curriculum in the importance and differences in delivering healthcare across these different communities, whether it's Indigenous or not. I was wondering how what you've learned about healthcare delivery and education across the province. And Salas mentioned Prince George, but it could be anywhere.
Yeah. I believe that working in rural areas, you need a different skill set or additional skill set than working in urban areas. And so the question is, do we prepare our student differently in our small, beautiful site than you would prepare students in urban settings. I think, yeah, like, let's go back how the situations are in rural areas. You are sometimes alone there. You have to you have limited resources. You need to decide on your own, making decisions, having not a backup net, cannot really double check with a specialist right away. This kind of requires, I would say, courage and comfort with uncertainty, but probably also the tolerance for risk, which is very, very different in urban settings. There you have the specialists around you. You always have a team you can double check with, and images and resources are way faster to access than in rural areas. So students need also develop this, what I just said, like the tolerance for risk and being comfortable with uncertainty. But on the other side, it sounds very negative or very challenging, but on the other side, it is also some beauty around it in rural medicine, right? So you have you can have a very close relationship with the community. You live with the people you care for in the communities. And this is something what urban physicians don't experience. The close relationships, the caring part of the community for each other, but also you are not anonymously there, right? They all know you, and you have to be, like, decisions carry weight. That's what I'm saying. I'm not saying in urban setting it doesn't carry weight, but it makes you're more aware of the weight what your decisions carry. And it is really a different way of practicing medicine in rural settings versus urban settings. And you both are in Vancouver, and sometimes you are not so much aware of these differences when you are not, when you don't have experience within your education to go out there in rural areas and see for yourself and experience it. But I think it is worth it because it gives you a different sense. You understand the system better, you understand the rural problems better, and you also understand the art of medicine better because it's not only in your secured little department in urban setting. Yeah, so I would recommend that you also try to get some experience in rural areas. You will not regret it.
I think that makes a lot of sense. And just to round off this topic, I did have one question, which would be, for us being in Vancouver, going and seeking experience in the rural areas, something that we do have control over, and that could be very valuable, like you've described. But let's take something that we don't have control over, which is going to medical school in Vancouver. Given that you spend the majority of your time, at least, teaching students in Prince George, in the more rural campus. What do you think? Have you noticed anything that you think really benefit the students in terms of the medical school education? It could be even the environment, to be in Prince George rather than being in the larger cohort in Vancouver. What are some things that Delbert and I may be missing out on as a result of that?
Yeah, I like we, right now we have 40 students per cohort, and they have it depends from year to year, the intensity, but they all develop a very close tie to each other, because they have to, right? They work so closely together, they almost live together for the first 2 years. Then in year 3 and 4, it's a little bit different. They learn in a close community, which in a big cohort like in Vancouver, you don't have this experience. You also cannot choose your peers. They are there. These are your peers. Like it's in Vancouver, you can choose who you want to hang out with. Here, these 40 students, like it's a classroom full, they have to get along. They grow quite close to each other. Not always. When, of course, there can be tensions which you have to deal with it, because you cannot avoid these people. But I do find that the joy outweighs the problems you have when you can choose you. And I observe that they love to laugh, more than in other medical schools. I see a lot of joy. And maybe this joy comes from being so comfortable with each other, and knowing each other so well, that it just is a very personal experience for them, and not a profession that they go to medical school. It is more a personal experience to go through medical school together.
So it sounds like they are not only learning the knowledge and the skills as we talked about previously, but they're going through all of this together, and they develop almost a shared understanding, if not identity.
Yeah.
And to just segue from this identity, we want to ask you about your own research on professional identities in medicine. And this is something Silas and I are quite interested in, because previous to medical school, both of us had, very different identities. Me, I was in research. Silas, he was, doing all sorts of things. So
I should just
how?
interject. All of them
Oh,
legal.
sorry. Go
All
ahead.
of them legal, by the way. All of them
Oh,
legal.
yes.
Must say.
I guess I made it sound a little bit suspicious there, but no,
Little
we're
shady.
both very much on the right side of the law. So I guess, Julia, could you talk a little bit about how identity develops in medicine, maybe from your own experience or what you've observed? Yeah.
Yeah, professional identity I find this topic very interesting, because when you are in medical school, you don't, and also in residency, you don't really realize that your way of thinking, your way of acting, is related to your profession, and that it changes over the years. And when I say professional identity to students, it is really hard to explain what it means. But I give you an example, and I think professional identity is actually really, really important. Which values it reflects, and this hasn't changed over thousands of years, right? So Hippocrates also defined main values for professional identity for the physicians. And one example is, and I think this is actually not an example, is an important core or value of our professional identity, is that we advocate for the individual. We advocate for the patient. The patient is our number one concern. And this means, on the other side, it is not our concern what the budget is or what the resources, or what our concern is the patient in front of us, what is in the best interest for this patient. And I can name you a lot of situations where you might think like, gosh, how should I react here? For example, when the insurance comes to you and wants information about the patient, if this patient was drunk during the accident or whatever, and you are like, torn. But when you remember, my professional identity is to patients number one and their interest, then you deny any information to the society, which might be different you as an individual, a private individual, where you think, oh, what, he was drunk and driving, that's absolute against any values I have. Of course, I rattle him out to police or insurance. That might be your personal reaction to it. But as a professional, as a physician, in the role you have as a physician, the patient is number one. And I think this example kind of shows professional identity, what it means, professional identity. Of course, it is such a huge topic that we could talk forever about professional identity and how individuals choose different parts of this professional identity, and which priorities of values and so on. But I hope you got a little bit an impression, because as a student, it's very hard to say, well, what does it mean? But you grow into the role of physician over time, and then you reflect and say, okay, actually the values of my profession influences me and also my actions overall.
It's so interesting. And maybe I could just ask one more pointed question on the topic, and then we can finish off here. Of course, respectful of your time, Julia. So, just on this topic, I'd be curious if any of your research or just personal reflections relate to this topic, which is, what about professional identity when it comes to healthcare and all the different professions within healthcare, and how one's professional identity may be situated within the hierarchy that exists in healthcare. For example, could we be doing anything different for our nursing staff, who, as we all know, run the hospitals and enable the healthcare system to keep functioning, but may, for one reason or another, see themselves lower on the hierarchy and feel like they need to be subservient to physicians, et cetera? That's just an example. But any reflections on that topic would be fascinating to hear from you.
Yeah. So one research area is about, I'm very interested in and doing research right now about stereotypes and professional identity. So stereotypes is how others perceive you from the outside. Professional identity, how you perceive yourself, and both within the healthcare system. And unfortunately, we still have a lot of stereotypes, which are kind of a barrier, especially when it comes to teamwork, interprofessional teamwork, right? So these stereotypes are very resilient. We don't get rid of them. And so the big question is, like, do they actually start to develop in the beginning of our educational path? And what can we do to influence it in a better way so that we have less negative stereotypes regarding hierarchy and responsibilities and skills? Okay, that's a little bit more into my research project right now. I have seen that former nurses who then studied medicine, and so I met them as medical students, have a different way of presenting themselves, a different self-confidence level. And I was thinking, why? Why are you should have all the self-confidence in the world, and yet it is not there, till I realized, students, they have a nursing background. And then when I got in a more deeper conversation with them, they told me how their professional identity as a nurse was always never trust yourself, double check, don't do decisions without the physician, and this influenced them so much that their behavior, their self-confidence behavior, even then when they were medical students, was hindering. And I thought, that's so interesting. Maybe we should look what the differences are in how we treat nursing students from our society, like how our society treats nursing education versus medical education, and does it have an influence how they see themselves? So what kind of professional identity, or to use this word again, they develop. And maybe this is a huge difference where we can try to shine a light on it, that, with other words, consciously not to try to put the nursing students, to teach nursing students that they, for example, shouldn't trust themselves. And I'm very simplifying here. I know that this is not correct how I say it, but I'm just saying extremely so that it's easier to understand where my research goes to. But yes, I think we could talk about this. It's a very interesting topic because it influences our healthcare system so much, how we as healthcare provider treat each other, but also the experience of the patients get very influenced by the hierarchy of the professional identities.
Yeah. Like if you can't trust yourself to make a decision, how are you going to make the right decision, right? I think at a more systemic level, even though the effect size might be smaller, is I've seen a couple of my classmates in medical school who they have this sense of self-doubt, mainly because they took a long time to get into medical school. And personally, I didn't really understand this because, as I mentioned earlier, I didn't really think about medicine until later on. But some of my classmates who applied maybe 2, 3, 4 times before getting into medical school, I feel like they have this sense of inferiority, that they're not doing enough. They don't match up against other people. But I think the majority of people that I've seen in medical school, that I've talked to, are brilliant. They're all hardworking and very, very driven to succeed. But I don't know what the long-term consequences or effects of these, identities will be, but it is something that I've noticed.
Yeah. This would bring us to admission process, right? And I don't really have the solution there, but it also breaks my heart when I have a brilliant student in front of me. And as you said, this student tried, I had students who tried 7, 8 times to get into medical school. I think it's also a loss for the society because this student later on will work 8 years less as a physician. But it also does something with you and your self-confidence. You don't have the lightness anymore, right? When you tried multiple times to get into medical school because this is your passion or your calling. And it is, I admire the resilience of some of these students who don't give up. But the good thing is no one fails medical school. So the moment you are in, you will graduate more or less.
Yep.
I don't more.
Well, hopefully.
We're not
That's
there
the
yet.
good part.
Wow, that was so fascinating. And you know what, Julia, just want to thank you so much. You gave us and the listeners so much food for thought. And I just want to make a comment, which is that, you know, for our listeners that are medical students or just in healthcare, or maybe individuals who are hoping to get into medical school one day, that just rest assured we have such brilliant and compassionate and amazing people behind the UBC Medical School program who care about the students so much, as I'm talking about you, Julia. So thank you. Speaking of stereotypes, thank you for breaking the stereotype of the, you know, maybe evil administrator who's just out to get us. So,
No,
so
the
yeah,
students are the most important stakeholders, right? The students are the most important stakeholders and the most important part of university, of medical school. And it's a huge pleasure and joy to work with students and see them grow and develop. And I can learn a lot from my students. Sometimes I think I learn more from them than they learn from me, but thank you for your nice words.
well, that's very humble. Thank you. And just before we finish, there's something we like to do with all our guests. We're just going to ask you a few rapid fire questions, silly questions, and it's just whatever the first word or answer comes to your head. Are you ready?
Can I ever ready for that? Okay, yeah, that's fine.
Okay, here we go. Okay, here we go. ENT or PB&J?
ENT.
Okay, smelling or hearing?
Smelling. It's the very first sense. It's the oldest sense we have. And it is, I could talk a lot about it, but like
Wow.
short answer, smelling.
Maybe for next time. Okay, here's a loaded question. Urban or rural? Oh.
Yeah, so the rural has my professional heart.
Mm-hmm.
But Vancouver, I'm also a city girl. So I'm emotionally a little bit conflicted there.
All right. Best surgical instrument to use in the kitchen?
Oh.
Oh. I wanted to say sucker, but I don't really use sucker in the kitchen. But sometimes I would need one in the kitchen.
All right, let's go with sucker. Yeah.
Sucker.
Okay, here we go. Moving on. Beer or schnitzel?
Well, I grew up that beer is not really alcoholic. It is like bread, so I go with beer.
All right. Whistler or the Alps?
Both amazing. Whistler getting too expensive, so I go with the Alps.
Oh. All right, and last one for you here. Most underappreciated human organ?
Oh, I would say the vestibular organ in the ear.
Wonderful answer. Wonderful answer. Okay.
Yeah, balance is
Julia,
important,
thank you.
Right?
Absolutely. I don't know where I'd be without mine. Life would just feel off kilter. Julia, thank you so much for your time. It really was a great pleasure, and we wish you nothing but the best.
Yeah, thank you so much. And yes, balance is important also in life. Okay, take care. Thank you so
In
much.
life and also vestibularly.
And in anatomy, yeah. Okay.
So that was our conversation with Dr. Julia Wimmers-Klick. Saus, what do you think?
I really enjoyed that conversation. Not only was she just a lovely and charming person, but it was really cool to get some insight into what kind of goes on behind the scenes. I think as we reflect on what it's like going through school, we're left with a lot of questions around the thought and intention that goes around designing our curricular activities and our learning. And it really is a black box most of the time. We're able to provide feedback, etc., but more or less it feels like a black box. And so I really enjoyed talking to someone who could give us some insight into what it's like behind the veil, so to speak.
And personally, one of the biggest takeaways I got from that conversation is her perspective on identity. In particular, as we mentioned in our conversation, both you and I have had different identities over the years. And perhaps because we are older and because we've had these different identities, it has, at least for me, been a little difficult grasping how I'm supposed to mold myself into a more, quote unquote, physician-like identity, if that makes sense, which, as you guys heard, is actually quite different and very important for being a physician, both in terms of patient care, but also having a healthy identity. So that is, for our own health and benefit.
Yeah, absolutely. And I found it interesting just on that theme when it comes to when she was talking about personal versus professional identities. It's interesting to me, like, yeah, we're all going to have a different identity personally and professionally, but it's interesting how these two kind of merge together and how we bring our own unique identities, backgrounds, and personalities into the formation of our professional identities, because they are separate. But if we think about a Venn diagram, they're not completely untouching circles, if I can put it that way. They do overlap. But it's fascinating how to think about how that develops. And the word identity it's really a buzzword these days in the past few years, and I think it gets used a lot to the point where people are a bit numb. Maybe people are a bit tired of hearing about this word identity. Oh, everyone has their own identity.
Maybe in this
but really, when
podcast.
you stop, maybe in this podcast. But you know what? When you really stop and think about it, you realize it's really just an important topic that is unescapable, unavoidable, and I think that's why we keep on returning to it.
And I like that we actually defined it over the course of the conversation, that identity is how you understand or how you see yourself, whereas how others see you, we refer to that as stereotypes. But of course, these two things are closely intertwined and affect each other.
Yeah, absolutely. And I just have so much food for thought after. I think I'm going to be thinking about it for the rest of the day. And I hope everybody enjoyed it as much as I did. We'll see you next time. And we hope to bring an awesome string of guests to come covering a wide range of topics. So stay tuned. And as always, that was Two Guys in Scrubs. If you want to support the podcast, leave us a like, a review, wherever you listen to your podcast. Thanks for listening, and we'll see you next time. Give me a jingle or something here.
Jingle, jingle, jingle.
Jingle, 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 jingle.